alterations in cognitive systems, cerebral hemodynamics, and motor function. Cognitive functions involve awareness of self and the surrounding environment. Consciousness is the combination of two critical components: arousal, or the state of awakeness, and awareness, which includes all cognitive processes. Disturbances in either domain can indicate serious neurologic conditions requiring immediate evaluation. Alterations in arousal are commonly classified by their origin. Structural causes include lesions located supratentorially, above the tentorium cerebelli, or infratentorially, below it. Supratentorial lesions may cause either localized or diffuse brain dysfunction. Infratentorial lesions often damage the reticular activating system or brainstem, resulting in profound unconsciousness. Metabolic causes of altered arousal include hypoxia, hypoglycemia, and electrolyte imbalances that impair cellular energy supply. Psychogenic unresponsiveness, though rare, may resemble coma but occurs in individuals who are physiologically awake. It is often associated with psychiatric disorders and requires a multidisciplinary approach for diagnosis. In evaluating a patient's level of consciousness, several neurologic functions are essential. First and foremost is the level of consciousness itself. This is the most critical indicator of brain function. Next, we assess the patient's pattern of breathing, paying close attention to its rate, rhythm, and overall pattern. Pupillary reaction is another key observation, helping us detect signs of brainstem dysfunction. Oculomotor responses, whether resting, spontaneous, or reflexive, can reveal subtle changes in cranial nerve function. Finally, we evaluate motor responses, which can help localize which side of the brain has sustained the most damage. Together, these clinical assessments guide our understanding of the patient's neurologic status and potential areas of injury. When evaluating a patient's level of consciousness, one of the most revealing clinical signs is their pattern of breathing. Different areas of the brain control different respiratory rhythms, and when these areas are injured, the breathing pattern changes in distinctive ways. Let's start with Cheyne-Stokes breathing, shown in waveform A. This is a crescendo-decrescendo pattern of breathing followed by a period of apnea. It often indicates bilateral dysfunction of the cerebral hemispheres or metabolic abnormalities affecting the brain. It's slow, rhythmic, and usually seen in critically ill patients. Moving to waveform B, we see central neurogenic hyperventilation, a deep, rapid breathing pattern that doesn't stop. This pattern is typically linked to damage in the midbrain or upper pons. Patients breathe rapidly regardless of their oxygen or carbon dioxide levels, and this can quickly lead to respiratory alkalosis. In waveform C, we observe apneusis, a rare and dramatic pattern. The patient takes a deep breath, holds it for several seconds, and then slowly exhales. This irregular rhythm is associated with lesions in the lower pons. Now, look at waveform D, cluster breathing. Here, breaths come in clusters, followed by periods of apnea. This irregularity usually reflects injury to the lower pons or upper medulla. It's unpredictable and often indicates a worsening neurological condition. Finally, waveform E represents ataxic breathing, an erratic and chaotic pattern with no rhythm at all. This breathing pattern signals severe damage to the medulla, the area that controls our most basic life functions. It often precedes respiratory arrest. Understanding these breathing patterns not only aids in diagnosis, but also helps localize brain injury. It's one of the many silent ways the brain tells us something is deeply wrong. When evaluating a patient with altered consciousness, pupil size and reactivity provide vital insight into brain function. The eyes are a window into the brainstem, and subtle differences in pupils can reveal exactly where the damage lies. Let's begin with a normal pupil, small, reactive, and regular. This may be seen in patients with metabolic imbalances or diffuse bilateral hemispheric lesions, such as hydrocephalus or thalamic hemorrhage. Although consciousness is impaired, the brainstem is still intact. Now, consider diencephalic dysfunction. Pupils become small and reactive, often bilaterally. The diencephalon lies deep within the brain, and its involvement suggests early or evolving brain injury. With third cranial nerve dysfunction, the affected eye shows a sluggish, dilated, and fixed pupil. This is a red flag for increased intracranial pressure or uncal herniation compressing the oculomotor nerve. It's one of the earliest and most dangerous signs of brainstem compression. Next, we have midbrain dysfunction, where both pupils become mid-position and fixed. This is a severe finding, indicating damage at the level of the midbrain, where crucial centers for eye reflexes are located. Pontini dysfunction produces pinpoint pupils, so small they appear almost closed. This occurs because of disrupted sympathetic control, leaving parasympathetic input unopposed. Finally, tectal dysfunction, a lesion in the roof of the midbrain, causes large pupils with poor reaction, sometimes referred to as a fixed hippus. The pupils may fluctuate in size slightly, but do not react appropriately to light. In summary, by simply observing the size, shape, and reactivity of the pupils, clinicians can localize neurologic injury, assess severity, and prioritize life-saving interventions. Brain death is defined as the irreversible cessation of all brain activity, including the brainstem. The brain is no longer capable of maintaining internal homeostasis. Criteria include an unresponsive coma, absence of spontaneous respiration, no brainstem reflexes, a flat EEG, and the persistence of these signs after all appropriate diagnostic efforts. Cerebral death refers to the irreversible loss of function in the cerebral hemispheres, excluding the brainstem and cerebellum. Individuals with cerebral death lack behavioral and environmental responses, though the brainstem may still maintain autonomic functions like breathing and circulation. Following cerebral death, patients may remain in a coma or evolve into other states. These include a persistent vegetative state, minimally conscious state (MCS), or locked-in syndrome, where the individual is fully aware but unable to move or communicate except through eye movements. Selective attention is the ability to focus on specific stimuli while ignoring others. Selective attention deficits may be temporary, as in acute illness, or permanent, as seen in dementia or brain injury. Impaired attention can drastically affect learning, memory, and communication. Memory is a core cognitive function often affected in neurologic disorders. Types of amnesia include retrograde amnesia, where past memories are lost, and anterograde amnesia, where the ability to form new memories is impaired. Global amnesia combines both. Patients may also have deficits in image processing or executive attention, seen in disorders like ADHD, where maintaining focus and organizing tasks becomes difficult. Understanding the anatomy of the brain helps us pinpoint where cognitive, motor, and emotional functions are processed, and where they may fail in conditions like dementia or stroke. Let's begin at the top. The precentral gyrus, also known as the primary motor cortex, is the command center for voluntary movement. Just in front of it lies the promoter area, which helps coordinate complex motor sequences. Behind the central sulcus is the parietal association area, responsible for integrating sensory input, including spatial awareness and navigation. The primary visual area, located in the occipital lobe, processes incoming visual stimuli, while the corpus callosum bridges communication between both brain hemispheres. Deep within the brain, The thalamus acts as a sensory relay station, filtering and directing information to appropriate cortical areas. The temporal lobe, seen on the lower side of the brain, houses structures vital for memory and language. Within it, the hippocampus helps convert short-term memories into long-term ones. It's also where domain-independent declarative memory is managed, facts, names, and experiences. Nearby, the amygdala assigns emotional significance to memories and governs fear and reward responses. Moving forward, the olfactory bulb and basal forebrain are involved in smell and cognitive arousal, respectively. The dorsolateral prefrontal cortex manages executive functions like judgment and working memory, while the ventrolateral prefrontal cortex helps regulate decision-making and goal-directed behavior. Several of these regions are part of the limbic system, including the cingulate gyrus, parahippocampal gyrus, and amygdala, the emotional core of the brain. Alterations in awareness result from direct brain injury, such as ischemia or hypoxia, or indirect causes like toxins and metabolic disturbances. Damage can lead to sensory inattentiveness, where patients ignore stimuli, especially on one side of the body. A more severe form is neglect syndrome, in which individuals completely disregard one side of their visual field or body. Let's explore how specific areas of the brain, namely the midbrain tectum, thalamus, and hippocampal temporal areas, contribute to attention and memory, and what happens when they malfunction. First, focus on the midbrain tectum. This region is responsible for coordinating eye and body movements, the move component of attention. When this area is affected by ischemia, compression, or chemical injury, it leads to a disorder in spatial orientation. Patients may experience difficulty directing their gaze, impaired visual search, or even skewed attention toward certain objects, especially if a hemispheric lesion is present. They become easily distracted by irrelevant stimuli and may fail to shift attention as needed. Next, the thalamus, a deep, central structure, controls the engage component of attention. It helps filter out unnecessary stimuli and focus on what's relevant. When compromised by metabolic imbalance, ischemia, or direct injury, patients may fail to engage with new information or struggle to stay focused despite external cues. This is often seen in conditions like delirium or thalamic stroke. Finally, consider the hippocampus and related temporal structures. These regions store declarative memory, facts, events, and experiences. If damaged by hypoxia, trauma, nutritional deficiency, or infection, patients may experience anterograde amnesia, meaning they can't form new memories. Even if they're alert and oriented in the moment, they might forget conversations within minutes. This explains why individuals with early Alzheimer's may repeat the same question or story. These three systems, move, engage, and remember, must work in harmony for us to effectively interact with the world. When disrupted, we lose the ability to focus, shift, and retain information. Understanding these patterns helps us diagnose conditions like delirium, stroke, traumatic brain injury, and dementia with greater precision. Now we explore how damage to cortical association areas and frontal brain regions disrupts thinking, memory, attention, and behavior. These impairments aren't just academic concepts, they're clinical realities seen every day in patients recovering from stroke, living with dementia, suffering brain trauma, or undergoing substance withdrawal. We begin with the cortical association areas, which govern selective attention, image formation, and declarative memory. When these areas are injured, whether by ischemia, compression, or metabolic disruption, partial lobe function declines. As a result, patients may experience delayed reaction times and struggle to disengage their focus, making it difficult to shift attention. They may overlook key environmental cues or stimuli, a condition known as sensory inattentiveness. Most significantly, they may show signs of retrograde amnesia, the inability to retrieve past memories. Now, let's turn our attention to the frontal lobes. This region acts as the brain's executive command center, responsible for vigilance, detection, and working memory. Damage here, especially from trauma, metabolic imbalance, or drug influence, triggers a chain reaction of impairments. Reduced vigilance means patients stop scanning their surroundings, making them prone to accidents and safety issues. A loss of emotional tone emerges, often seen as apathy or lack of motivation. Working memory deteriorates, leading to failures in goal setting, planning, and following through on even the simplest sequences of activity. But the impact runs deeper. Individuals may become indecisive, unable to initiate or maintain action, and may even struggle to stop once a task has begun. Some repeat behaviors inappropriately, a condition known as motor perseveration. Others demonstrate what we call loose-state errors, where they drift away from the task or thought at hand without realizing it. Frontal lobe damage also impairs self-monitoring. Patients might believe they're performing well when they're not, or fail to use feedback to guide and improve their actions. These symptoms aren't simply memory lapses. They represent a breakdown of executive function. Sadly, they're often mistaken for laziness or lack of cooperation. By understanding where these behaviors come from, we shift the clinical lens from judgment to insight. And with that shift, we gain a more effective and compassionate approach to diagnosis, treatment, and rehabilitation. Cognitive impairments may present as agnosia, an inability to recognize objects, sounds, or tactile sensations despite normal sensory function. Aphasia is a language deficit, often due to stroke, and can be categorized into types such as expressive aphasia, difficulty speaking, receptive aphasia, difficulty understanding, and global aphasia, which includes both. These deficits significantly impact communication and independence. Acute confusional states are transient disorders of awareness and cognition, typically due to disruptions in neural networks. The most well-known is delirium, which may be hyperactive, marked by agitation, or hypoactive, where the person appears drowsy and disengaged. In contrast, dementia is a progressive, long-term decline in intellectual functioning, including memory, reasoning, and language. Dementia results from progressive neuron degeneration, brain tissue compression, atherosclerosis, or neuroinflammation. Patients progressively lose memory, orientation, language skills, and judgment. Unlike acute confusion, dementia is chronic and irreversible, and its underlying cause determines the rate and nature of decline. Alzheimer's disease, or AD, is the most common form of severe cognitive dysfunction in older adults. It may present as sporadic late onset, familial early onset, or non-hereditary forms. The exact cause is unknown, but genetic and environmental risk factors are involved. The disease typically begins gradually, with subtle memory loss and emotional changes. Pathologic changes in AD include the buildup of neuritic plaques made of beta amyloid and the formation of neurofibrillary tangles composed of tau protein. Early symptoms include forgetfulness and emotional instability. As the disease progresses, patients experience confusion, disorientation, and loss of problem-solving skills and judgment. Diagnosis is often by exclusion of other causes. Visuals may show cross-sections of a healthy brain compared to one with Alzheimer's, highlighting cortical atrophy and enlarged ventricles. These structural changes reflect the cognitive decline experienced clinically. Early detection remains key, though current treatments are supportive rather than curative. Vascular dementia results from cerebrovascular disease, such as stroke, atherosclerosis, or chronic hypoperfusion. It is often abrupt in onset and progresses in a stepwise fashion, especially when caused by multiple small infarcts. Cognitive symptoms vary based on which brain regions are affected, but memory, attention, and executive function are commonly impaired. Frontotemporal dementia is a rare condition caused by degeneration of the frontal and anterior temporal lobes. It is often hereditary and linked to gene mutations. Unlike Alzheimer's, early symptoms usually include changes in behavior, personality, and language rather than memory. As it progresses, patients lose empathy, become socially inappropriate, and may develop motor symptoms. A seizure is a sudden and temporary disturbance in brain function caused by excessive electrical activity in the brain's cortical neurons. These discharges disrupt the normal rhythm of communication between neurons, leading to a wide range of symptoms, from convulsions and sensory changes to altered consciousness. It's important to remember, a seizure itself is not a disease, but a clinical sign of underlying neurological dysfunction. When seizures become recurrent and unprovoked, we call this condition epilepsy. Seizures can result from a wide variety of conditions. Metabolic disorders, such as low blood sugar or electrolyte imbalances, can trigger abnormal neuronal firing. So can congenital brain malformations, genetic predispositions, infections, and brain tumors. Seizures may also follow perinatal injuries, postnatal trauma, or occur as part of myoclonic syndromes. Finally, both vascular diseases and substance abuse or withdrawal are significant contributors. Recognizing the root cause is essential for effective treatment. Seizures are categorized based on their clinical presentation, where they originate in the brain, how they appear on electroencephalogram recordings, and how they respond to treatment. Some seizures begin in a specific, localized area of the brain. These are referred to as focal seizures. Depending on where they start, they may or may not impair consciousness. Other seizures are generalized, meaning they affect both hemispheres of the brain from the very beginning. Generalized seizures often cause a loss of consciousness and involve widespread motor movements. Beyond these categories, certain patterns of seizures are grouped into what are called epilepsy syndromes. These syndromes include not only the type of seizure, but also factors like the age at onset, underlying genetic causes, and the likely course of the disease over time. Accurate classification helps guide diagnosis, treatment planning, and long-term management for patients living with seizure disorders. The seizure process has distinct phases. The praectal phase includes both the prodroma, early signs like irritability or malaise, and the aura, an immediate warning that the seizure is coming. The seizure itself is the ictus, the active phase involving convulsions or altered consciousness. After the seizure ends, the postictal state begins, characterized by confusion, fatigue, and sometimes temporary neurological deficits. In severe cases, patients may experience status epilepticus, a continuous or rapidly repeating seizure without full recovery between episodes. This is a life-threatening emergency requiring immediate medical intervention. Increased intracranial pressure occurs when the volume inside the skull rises beyond what the brain and cerebrospinal fluid can accommodate. The skull is a closed space, so any swelling, bleeding, or accumulation of fluid forces shift in the brain's delicate balance. Initially, cerebrospinal fluid is displaced to compensate, but as pressure rises, blood flow to the brain decreases, leading to tissue ischemia and further swelling. If left unchecked, increased intracranial pressure can result in brain herniation and death. The development of increased intracranial pressure progresses through 4 distinct stages. Early on, the body tries to maintain blood flow by constricting vessels and shifting cerebrospinal fluid. As pressure worsens, brain tissue becomes increasingly compromised, oxygen levels fall, and vital brainstem functions begin to deteriorate. Without intervention, this cycle rapidly leads to irreversible brain injury and death. Cerebral edema refers to the swelling of brain tissue caused by excessive accumulation of fluid within the cells or the spaces around them. This swelling can result from injuries that damage blood vessels, from toxic insults to the cells themselves, or from an increase in cerebrospinal fluid leaking into brain tissue. As the brain swells, intracranial pressure rises dangerously, threatening oxygen supply and overall brain function. Managing cerebral edema focuses on lowering pressure to prevent further neurological damage. Hydrocephalus is a condition where excess cerebrospinal fluid builds up within the brain's ventricles or surrounding spaces. This accumulation can occur because of overproduction of fluid, blockage within the ventricular system, or impaired reabsorption into the bloodstream. As fluid pressure rises, it causes ventricles to expand, compressing surrounding brain tissue and raising intracranial pressure. Hydrocephalus may develop rapidly in acute settings or progress slowly in chronic cases. Hydrocephalus is categorized based on how the fluid becomes trapped or accumulates. Non-communicating hydrocephalus results from a blockage inside the ventricles, while communicating hydrocephalus occurs when reabsorption is defective despite open pathways. Acute hydrocephalus develops quickly and is often life-threatening, requiring urgent treatment. In contrast, normal pressure hydrocephalus tends to occur more slowly, especially in older adults, and may mimic dementia or gait disorders. In this image, we compare normal brain anatomy with hydrocephalus, a condition characterized by an accumulation of cerebrospinal fluid within the brain's ventricles. On the left, the normal brain shows balanced fluid distribution and properly sized lateral ventricles, thalamus, corpus callosum, and pons. There is adequate space around the ventricles, indicating normal pressure. On the right side of the image, the brain of a patient with hydrocephalus shows severe enlargement of the lateral ventricles. This excessive fluid accumulation compresses surrounding structures, including the thalamus and corpus callosum. The third ventricle and interpeduncular fossa are also affected, indicating significant pressure buildup in the cranial vault. These changes suggest hydrocephalus, which can result from a blockage of cerebrospinal fluid flow, impaired reabsorption, or overproduction. Without treatment, the increasing pressure can cause brain damage. The MRI reveals the extent of fluid buildup, crucial for accurate diagnosis and management of hydrocephalus. Damage to the motor system can produce a wide range of deficits, depending on which pathways are affected. These alterations may impact muscle tone, movement initiation, coordination, or reflexes. Injuries to upper motor neurons, lower motor neurons, or the motor cortex itself may lead to either weakness or paralysis. Some conditions, like amyotrophic lateral sclerosis, progressively destroy motor neurons and severely impair movement over time. Changes in muscle tone are often one of the first signs of motor dysfunction. Decreased tone, or hypotonia, results in floppy or weak muscles, while increased tone, or hypertonia, causes stiffness and resistance to movement. Hypertonia can take several forms, including spasticity, rigidity, dystonia, and paratonia. These patterns are often seen in neurological diseases such as cerebral palsy or after a stroke. Some individuals experience hyperkinesia, which is characterized by excessive, involuntary movements. These may range from mild restlessness to large, violent spasms. Conditions like paroxysmal dyskinesias involve sudden, unpredictable bursts of movement, while tardive dyskinesia presents with repetitive facial and limb motions. Such motor disruptions are often linked to long-term drug use or basal ganglia disorders. Huntington disease is a hereditary disorder that causes the gradual breakdown of nerve cells in the brain. It is inherited in an autosomal dominant pattern and leads to degeneration of the basal ganglia, especially the caudate nucleus. The result is a loss of inhibitory neurotransmitters like GABA, which leads to uncontrolled, jerky movements and eventually cognitive decline. Symptoms usually appear in midlife and worsen progressively. Hypokinesia refers to a loss or reduction of voluntary movement, even when muscle strength and consciousness are preserved. Akinesia is the absence of movement, while bradykinesia refers to the slowing of movement. Patients may lose spontaneous movements like blinking or gesturing, making their behavior appear stiff or expressionless. These symptoms are most commonly seen in Parkinson's disease. Parkinson's disease is a neurodegenerative condition caused by the degeneration of dopamine-producing neurons in the basal ganglia. This results in hallmark symptoms such as tremors at rest, muscle rigidity, bradykinesia, and postural instability. Over time, Parkinson's disease can also produce changes in mood, autonomic function, and cognitive ability. It is a chronic and progressive illness with no known cure. As Parkinson's disease progresses, patients may adopt a stooped posture and develop a shuffling gait. Movements become increasingly rigid and slow, and balance is often impaired, increasing the risk of falls. These physical signs reflect deep dysfunction in the brain's motor control pathways. Early recognition and treatment can improve quality of life and delay complications. Injury to upper motor neurons disrupts the brain's ability to send motor commands down the spinal cord. This leads to weakness or paralysis, often affecting entire regions of the body such as one side or hemiplegia, both legs or paraplegia, or all four limbs or quadriplegia. Unlike lower motor neuron damage, reflexes are often increased and muscle tone becomes spastic. These syndromes are commonly seen in conditions like stroke, brain trauma, and multiple sclerosis. Damage to lower motor neurons affects the nerve fibers that directly stimulate muscles. This results in flaccid paralysis, where muscles become limp and reflexes are lost. Over time, affected muscles may atrophy due to disuse, and spontaneous muscle twitching, called fasciculations, may be observed. Lower motor neuron syndromes are seen in spinal cord injuries and peripheral nerve disorders. Motor neuron diseases are a group of progressive disorders that affect either upper motor neurons, lower motor neurons, or both. Examples include Guillain-Barré syndrome, spinal muscular atrophy, and progressive bulbar palsy. These conditions lead to weakness, paralysis, and eventually respiratory failure if untreated. Because they advance steadily, early diagnosis and supportive care are critical for improving outcomes. Amyotrophic lateral sclerosis is a devastating neurodegenerative disorder that affects both the upper and lower motor neurons. The disease causes a relentless progression of muscle weakness, beginning subtly but advancing to profound disability. Although the exact cause is still unknown, the hallmark of ALS is a steady loss of voluntary motor control. Symptoms usually begin with mild muscle weakness and gradually evolve into significant muscle atrophy, increased spasticity, and difficulty with fine motor skills and walking. As the disease progresses, it eventually impairs the muscles responsible for breathing. Sadly, ALS is almost always fatal, with most individuals passing away from respiratory failure within 3 years of diagnosis. Disorders of posture arise when there is an imbalance in muscle tone between different muscle groups. This inequality causes the limbs to assume abnormal positions, often involuntarily. One common example is dystonic posturing, which involves repetitive, twisting movements or sustained abnormal positions due to overactive muscles. More severe signs include decorticate and decerebrate postures. In decorticate posturing, the arms are flexed inward and legs are extended, suggesting damage above the brainstem. In decerebrate posturing, the arms extend outward and the legs stiffen, indicating more severe damage in the brainstem itself. Basal ganglion dysfunction can also lead to distinctive postural abnormalities, reflecting deeper motor system involvement. Gait disorders are abnormalities in walking patterns that result from dysfunction in specific areas of the nervous system. When upper motor neurons are damaged, patients often exhibit a spastic gait, characterized by stiff, dragging movements and reduced flexibility in the legs. If the cerebellum is affected, balance and coordination suffer, leading to an ataxic gait that appears wide-based and unsteady. Basal ganglion disease can cause a shuffling, Parkinsonian gait, while damage to the frontal lobes can result in a hesitant, short-stepped walk that reflects both cognitive and motor impairment. Disorders of expression interfere with the motor aspects of communication, affecting how emotion and intention are conveyed through movement and speech. Hypermimesis refers to exaggerated emotional expression, where responses are disproportionate to the situation. Hypomimesis, on the other hand, results in a flat, expressionless face and voice, often seen in depression or neurological disease. Dyspraxia or apraxia disrupts the ability to perform learned, purposeful movements, making it difficult to carry out gestures or spoken commands even when strength and coordination are preserved. Extrapyramidal motor syndromes result from dysfunction in motor control pathways outside of the primary motor cortex, particularly in the basal ganglia and cerebellum. When the basal ganglia are affected, there is often an imbalance between dopamine and acetylcholine, which leads to symptoms like rigidity, tremors, and slowed movement. This imbalance is a hallmark of conditions such as Parkinson disease and Huntington disease. Patients may also exhibit involuntary movements or posture abnormalities depending on which circuits are disrupted. Cerebellar motor syndromes involve damage to the cerebellum, the brain's coordination center. These syndromes primarily cause ataxia, a loss of coordinated, smooth muscle activity. Individuals may struggle with walking, speech, and fine motor tasks, even if muscle strength remains intact. Importantly, cerebellar disorders usually affect the same side of the body as the lesion, which helps in localizing the problem clinically.